How's it going, guys? We have a pass level question for cardiorenal steps 1 and 2. You have a 26-year-old dude who's got renal failure. That's literally what we're telling you here, not complicated. Normal creatinine 0.7 to 1.2. Once you've hit a creatinine of 2, you've lost 90% of your renal function. So we've got really bad renal failure, and then we've got pericarditis. This is uremic pericarditis when you have a friction rub in the setting of renal failure. So what are we going to see on an ECG is our first question here. Well, what are you going to see for pericarditis? You're going to see diffuse ST segment elevations, very buzzy. Now, electrical alternans, in contrast, this is going to be pericardial effusion. So they can say electrical alternans with low voltage QRS complexes. So pericardial effusion / cardiac tamponade, that's what you can see. Some of you who are very astute / pedantic could contend that you can sometimes get a pericardial effusion concomitant to / secondary to pericarditis. But if you're going to choose one finding, it's going to be clearly the diffuse ST segment elevations. USMLE doesn't give a fuck about PR depressions, okay? It's to my observation, students tend to mention that as the salient ECG finding, but it's the ST segment elevations that are most important. Okay, so what are we going to expect for bicarbonate and renal failure? It's always going to be a down arrow. Remember that uremia, don't confuse with hyperuricemia, completely different. Nothing to do with uric acid. Uremia means renal failure. Okay, and U in mud piles, the mnemonic for high anion gap metabolic acidosis. So you have a down arrow for bicarbonate, metabolic acidosis, right? And this is two reasons. One, you can't reabsorb bicarb as effectively in the PCT in the setting of renal failure. And also you can't secrete protons in the cortical collecting duct under the action of aldosterone the way you're supposed to. So got a metabolic acidosis, high anion gap. So we're looking at these four answers here. And then you need to know for calcium, it's going to be decreased in the setting of renal failure. Okay, just ignore the middle one I've highlighted here. But so it's going to come down to this top answer here, this bottom answer, calcium's down arrow. So it's two main reasons why calcium's decreased in renal failure. Number one, you can't reabsorb it the way you're supposed to in the late DCT under the action of PTH. Okay. The second main reason is you can't activate 1-alpha hydroxylase in the PCT of the kidney under the action of PTH the way you're supposed to. So you can't synthesize 125D3. That's really important. They could have that as a down arrow as well in renal failure. So decreased active 125D3. You can't absorb calcium in the small bowel the way you're supposed to. Hypocalcemia. Okay, so hypocalcemia is going to cause PTH to go up to compensate. This answer. I'm like, so many fucking arrows here, I can't even see what the correct answer is. So we've got diffuse ST segment elevations. We've got a uremic pericarditis here. You got a high anion gap metabolic acidosis, decreased bicarbonate. You're going to have decreased calcium with decreased 125 active D3. And then PTH is going to go up to compensate. Okay, it's called secondary hyperparathyroidism. And one final point that I'll just quickly mention is if they give you the arrow for phosphate in renal failure, it's always increased, okay? So the reason this can cause some confusion is because if you have vitamin D deficiency not related to renal failure, just rickets, osteomalacia, let's say dietary deficiency as an example, you'll have a down arrow calcium, down arrow phosphate. However, if renal failure is the cause of your vitamin D deficiency, you have an up arrow for phosphate, not a down arrow. The renal failure wins. Okay, so that can cause some confusion. So it's like, wait, but you got vitamin D deficiency. How do you have an up arrow phosphate? The renal failure wins, where you can't filter out the phosphate the way you're supposed to. So, short point of consolidation, you're going to have diffuse ST segment elevations, pericarditis, down arrow bicarbonate, metabolic acidosis, down arrow calcium, and then PTH goes up to compensate. You know the deal. Once you make more content, I'm going to subscribe to my channel. Appreciate your time. That's it.